The beauty is we can literally make a three-dimensional image of a patient's body, and we can see exactly where the medication is at any point in time. And we can prove to ourselves that they're not going anywhere but the cancer. And as a result, the side effect profiles of these are phenomenally good.
There's a new class of drugs called radiopharmaceuticals, which deliver radiation therapy specifically to certain cancer cells. That's what we're talking about today on Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thank you so much for being with us. We have two special guests today. Dr. Geoffrey Johnson is joining us from Mayo Clinic. He's the chair of the Division of Nuclear Medicine and is a radiologist and nuclear medicine physician. In the interest of transparency, you should know that Dr. Johnson is the Chief Scientific Officer at Nucleus Radiopharma. That's a drug manufacturing and supply chain company in collaboration with Mayo Clinic. Also joining us is Dr. George Sgouros. He's the director of the Radiological Physics Division and is a professor of radiology and radiological science at Johns Hopkins School of Medicine. He studies what kinds of doses are needed for these new therapies, again, known as radiopharmaceuticals. Thank you so much for being with us, gentlemen. We appreciate it.
It's a pleasure, Kathy.
Likewise, a pleasure.
Now, you both are respected researchers who focused your professional attention on cancer. Dr. Johnson, I'm going to start with you. How did your cancer journey begin?
Well, I was a medical student, first-year medical student, and I noticed a lump not supposed to be there. And unfortunately, in this case, I ended up having a rare sarcoma that was growing, that was not following the rules, and it was cancerous. And I had to go through therapy while I was training in a medical scientist program in the very beginning of my years in training. Luckily, that was, well more than 20 years ago. And the science that was newly available at that time was life-changing for me. But it certainly could have been better.
Given your background, could this be done differently?
So my cancer was myxoid liposarcoma in my arm. And the goal was to get rid of it and never have it come back. 20 years before I was diagnosed, they would have just cut off my arm. Simple, right? But with the advancement of radiation therapy from external beam, they were able to radiate it prior to surgery and then during surgery radiate it even more. And so they were able to save my arm and my hand, which is a phenomenal advance at the time. But the radiation therapy did a lot of damage to the normal healthy tissues of my arm. And so I have chronic fractures in my arm. And so therefore, I can't depend on my left arm to be useful, right? So small price to pay, super excited by what Mayo Clinic was able to do for my therapy at the time. And I'm, knock on wood, cancer-free.
Those who've had cancer say it's a life-changing, can be a life-changing diagnosis. And I'm wondering, given that you've traveled this road, has it changed your look at how you do your research, how you interact with patients?
Well, certainly it's a way to bond with my patients. So, I see patients who are suffering from usually metastatic cancer and going to treat them with these radiopharmaceutical drugs. And, when they understand that you as a physician understand a little bit better what it feels like to be a patient, it just really makes them feel like you're on their team. So I definitely share that in that interaction, especially when I feel like it would be helpful. But you don't have to go through cancer to be touched by cancer. There are millions of people who unfortunately die of cancer and many, many who survive.
Let's talk about radiopharmaceuticals. The research I have done on it, wow, it is truly amazing. We're talking now about targeting radiation therapy at the cellular level, but delivering radiation directly to cells isn't itself a new approach. I'm curious, Dr. Sgouros, as a pioneer in this field, what changed?
So one of the main advances was, really, as the field grows, finding molecules that recognize tumor cells. Second, the chemistry that can take those molecules and label them with atoms that emit short-range radiation. And then all the surrounding technology to do the imaging, to understand the absorbed dose delivered to the tumor versus to normal organs. So really, it's a multidisciplinary thing. And I think that's a big part of what makes the field very exciting.
What do you think, Dr. Johnson?
Well, I think the field has absolutely transformed in the last decade. It's just a phenomenal journey to go on. If you think 80 years ago, you had doctors in Harvard and Mayo Clinic treating thyroid cancer with radioactive iodine. It was the very first thing that we figured out how to treat cancer with a radioactive atom. And it's taken a long time, and we've had a lot of false starts where we developed a molecule, it just wasn't quite right. But as we learn how the body communicates, like how cells in the body talk to each other, we can tag along. We can basically take what we've learned and say, well, rather than having the molecules communicate to each other and tell the cells information, we're going to make those molecules radioactive. And we're going to design them so that they go to cancer. And then, so we tag along, we use the biology of the human body to our advantage. And the people studying cancer come up with, okay, these are unique things that the cancer cells are doing wrong. And they're unique things about the cancer that we can use to our advantage that the healthy cells aren't doing. They're expressing proteins, targets, things we can stick these drugs to. So half of what I do is using these medications to see the cancer hiding in the body. We can use these same radioactive drugs, these radiopharmaceuticals, to go to the cancer and light them up. They literally give off energy we can see with our scanners. And those scanners, like PET scanners and SPECT scanners, they're getting orders of magnitude more powerful as the years go on. I mean, we just installed a scanner that is literally 10 times better than the scanner we had the year before.
So it sounds like it's almost like a, forgive my simplicity here, but like a heat-seeking missile in a sense, that finds these tiny deposits of cancer cells. Is that how then, Doctor, we can find some of the spread, the metastatic spread of cancer at times?
We've been treating cancer for I don't know how long. Modern 75 years. So with agents that, as you said, with chemotherapeutics, and we never really know where these things are going. Are they targeting the cancer or where are they going? So this new approach, actually, we can generate images that tell us where the therapeutic agent is going. So it's no longer the black box that it's always been. And that's really a fundamental difference in this treatment.
To what George just said, we can see where they go in the body, and therefore we have to do a lot of work to keep making the medications, the radiopharmaceuticals better, because we can see if they're not going where we want them to go. And unfortunately, or fortunately, it doesn't matter where the medication is. If it gives off its radiation, it's going to injure cells wherever it is. So it's on us to design the molecules to be extremely precise and only go to the cancer and not stick somewhere else and injure normal tissues. But the beauty is we can literally make a three-dimensional image of a patient's body, and we can see exactly where the medication is at any point in time. We can prove to ourselves that they're not going anywhere but the cancer. And as a result, the side effect profiles of these are phenomenally good. And that's where the patients seem to notice the difference. And I think that's really a critical aspect of why it's been so exciting, is the patients come back and say, I feel better now on the therapy than I did before it, which is phenomenal and very different than chemotherapy or surgery. You go through this healing process, you feel miserable. These patients say, hey, before I started therapy, I was at home with all these complications of my cancer. Now I'm out going to the grocery store. And it's really, really rewarding to treat patients with these kind of therapies.
Let me ask about side effects. Thanks for bringing it up too. With traditional radiation, you both know that there are two kinds of side effects, early and late.
Mhm.
And late side effects can include what? Damage to the heart and other organs, or maybe even second cancers that don't show up for years. So you mentioned the side effects of these new drugs. Are there the same potential issues with the late stage side effects, Dr. Sgouros?
Potentially. I think the big difference is that we can do calculations and understand how much radiation is being delivered to different tissues. There are a limited number of tissues where you can have potential toxicity. So we can do those calculations and understand when we need to stop so we can avoid both early and late effects. The early effects can be managed. It's the late effects that we worry about. What's interesting is I've heard anecdotally that patients receive this treatment and then they wonder whether they did really receive it because it's just so different, non-toxic relative to what they've experienced.
So would you both say that these radioactive drugs work better than traditional radiotherapy or chemotherapy?
They're kind of a combination of the two. And, if to say they work better, I want to cure a patient. We're not there yet, right? So right now, many patients respond very favorably to radiopharmaceutical therapy. So prostate cancer patients or patients who have neuroendocrine tumors in their pancreas or their small bowel are the populations we treat the most. But some of them, the benefit's fairly minimal. Unfortunately, their cancer is resistant to the dose we're giving or the kind of radiation we're giving. If we can give enough radiation safely to the tumors, we can kill anything. We can go after any type of cancer with this type of therapy. But it's on us to do exactly what George was describing and be very precise. We can see where they go. We can calculate with the special tools and things that people like George and others are developing. So we can estimate what we think a given patient is going to receive, and we can make sure we're in that safe zone. So right now we're trying to design therapies that go even better with better types of radiation. We have a lot of work to do. But the nice thing about it is there's no physical reason, there's no scientific reason why we can't get to a cure. So there's a lot of hope there, but it's not a perfect solution. And cancer finds a way to evolve. So as we go forward, we're actually combining these therapies with chemo. We're combining it with surgery. We're combining with external beam radiation and immunotherapy to try to use the different benefits of the two therapies so that we can get a better outcome for the patients.
There's a whole bunch of effort replacing the current radioactive atoms with ones that emit alpha particles, and that's a whole new game. With alpha emitters, cells don't even have that opportunity. It's not, changing a cell to not behave like a cancer cell. It's just outright killing the cancer cell. I say that's the best way. The best way to kill a cancer cell is to kill a cancer cell, not change how it behaves. You talk to an oncologist, cancer doctor, and they're not looking for cure. They're looking for 5-year survival.
Uh-huh.
And I think that these agents have the potential for cure because we're killing the cells. And, granted, cure is not a word that doctors really want to use. And again, it goes back to the dismal efficacy that we have with current agents.
Dr. Johnson, what do you think of that?
Well,
Pretty strong words from your friend.
I'm a huge fan of these next generation radiopharmaceuticals with alpha emitters. I'm a convinced believer. And the way I describe this to patients that I'm enrolling on trials where we're using these alpha emitters or others, because some of in the lab that I work with partners to develop these new therapies. If you think about a beta emitter, which is our current classic therapies, so that target prostate cancer and neuroendocrine cancer, a beta is a subatomic particle, okay? Get technical on you here. It's really, 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 really tiny. And it's basically an electron, and it's going to shoot across maybe 1,000 cancer cells and do a little bit of injury to all of them. So in order to kill a growth of cancer, a tumor, you have to get a lot of the medication to cells throughout the tumor, and all those crisscrossing electrons, those beta, eventually kill the cancer. The problem is, or one of the problems is, once the cancer gets really small, then most of those, if you give the patient another dose of the therapy to try to finally kill those last cells, it doesn't work because those little electrons are shooting out into healthy tissues because the tumor's tiny now. And that alpha particle that's 8,000 times bigger is only going to travel up to 3 cell diameters. So it's literally going to kill the cell it's on. And as George said, the cells really have no defense. I mean, what's a wall going to do against a fully loaded Mack truck? There's no defense. It can't adjust to it. So if we can get these therapies, we can kill the last remaining cells. We can kill tiny cells floating in the blood. And if we can combine that with other therapies, maybe turn on the immune system so it's going to mop up other cells, we have the ability to be much more precise and powerful.
Yeah, I mean, Jeff has really highlighted what's interesting about this field in that it's so multidisciplinary. He basically spoke physics, and that's pretty unique, for a cancer doctor to really delve into the physics of how the treatment works. Typically, the kinds of treatment that we have are very biologically oriented. This is sort of the first time that somebody treating with these agents needs to understand the physics. And I think that's part of why these agents haven't caught on as much as they should have.
Now, I'll admit to both of you, I did not do well in my physics or chemistry classes in college, but I know that radioactive isotopes don't have a long shelf life. Since they are key to these new medicines, what's the current system to get them to patients in a timely fashion?
Yeah, let me start with what was going on when we first launched the first prostate cancer modern radiopharmaceutical, which is targeting PSMA on the cancer cells. So when we were starting with that in clinical trials and then in practice, you had a manufacture of lutetium. This is a radioactive atom that comes from a nuclear reactor, was coming from Germany. That was going to Italy, where a facility was producing the drug. So you had, a drug manufacturing facility that would take the radioactive atom and would take the peptide or the binding molecule from another lab, put them together, and prove to everyone with all the specifications that the drug is made perfectly, right? That has to be done very quickly because once they sign off and say this drug is made to all the FDA specifications, you have 5 days. So 5 days after that point, they had to ship it all the way from Italy into the United States, and it had to get into the vein of one of my patients, or it was worthless. So the supply chain is very difficult. Having said that, one of the nice things about it is it goes away on its own. Like literally, it becomes just an inert, tiny amount of molecules within days to weeks, and it doesn't pollute. It's not like the long-term radioactive stuff we think of from like a nuclear reactor waste site. These are short-lived. So quite frankly, they're probably the least polluting thing you can imagine in terms of medical treatments.
And Dr. Sgouros, would you like to make a comment about this?
People are really afraid of radioactivity and radiation in general. And that's another one of these reasons that this field has sort of been limited. If we can figure out a way of making people more comfortable with the idea that radioactivity is key to successful treatment and not always bad, then that'll make a huge difference for the field.
Say, Dr. Johnson, again, I mentioned in the interest of transparency, you've recently started working with a new company called Nucleus Radiopharma, which works on improving the supply chain for these treatments. And this is a collaboration with Mayo Clinic. What's the overall goal?
From my point of view, and I was struggling with patient care and clinical trials in this space, and came to Mayo internally and said, we have to do this. We have to create this thing that's missing in the field. So how do we recognize the fact that the science is developing really rapidly and all these new technologies are coming, but each time we see these new therapies come along, the whole supply chain is fragile? Because I had hundreds of patients. They'd show up and they'd be ready for the therapy, and the therapy wasn't there for them. And it's a horrible experience. And you say, okay, if we're really going to make radiopharmaceuticals a staple core part of cancer therapy, then I want to, as a physician, be able to treat my patient quickly. The patient comes, they're scared, they want to get on therapy, they can go on chemo, they can get external radiation, they can go to surgery all rather quickly. But if I say, hey, in 2 weeks to a month, your therapy will be here, but it might not be here, and I can't control any of those things, and I'm going to reschedule you multiple times, they're going to stop using and being excited about these therapies because the supply chain isn't being invested in and developed as quickly as the science of these new molecules. The other thing I would say is when you look at the companies that are manufacturing these drugs, they're also the companies that own the drugs. So if you've got a scientist like George or someone like myself working with partners here who develops something we think is the next generation, you want to have a partner that will support the development of bringing those things forward so that we can see how they work. And you don't want to have to convince a drug company that already has a drug in that space to produce yours that's going to potentially be better than theirs. So Nucleus Radiopharma was created by Mayo and multiple academic centers, as well as industry investors and other investors, to try to solve those problems, and also not to own the drugs themselves. That's really the design here, so that it's an even playing field. We can get these new therapies to our patients quickly, and we can help the whole field move forward.
So I want to drill down a little bit deeper onto the patient experience here, into the patient experience, if I could. And Dr. Sgouros, you mentioned this, that there should be maybe some education with the effectiveness of these therapies when it comes to explaining them to patients, because people are afraid of radioactive materials. What would be your pitch to a patient? I know you're doing research, but what would be your pitch to a patient who might be a little apprehensive about undergoing some of these therapies?
I'd focus on toxicity issues, and there's this whole area about patient experience. Yes, we focus on efficacy and toxicity, but those are numbers. There should be an aspect that captures how the patients feel. And from that perspective, these agents are way ahead of anything else they've experienced.
Dr. Johnson, do you have an experience with a patient who might have been a little skittish about undergoing this therapy, and how they might have come around after they talked to you?
Yeah, absolutely. We spend a lot of time talking about this. Having said that, most of the time, by the time the patient gets to me, they've already talked with another physician, they've already gone online, and often they're coming to us for the therapy. So, despite the fact that radiation has this fear factor, which is something we definitely talk about, the first thing that they do is they talk to their buddies, right? I don't know how many times I've heard somebody say, "Yeah, I was golfing with this guy and he had this therapy and said it was great." Or they went online and they went on some social chat thing, and they were able to talk to and text with people and get an idea of what their experience was. The concept that radiation is bad is not true. This is kind of a philosophical thing, but if you look and say the sun is radiating the planet, that is literally the source of all life. The radiation from the sun leads to food, right? So we grew up in an environment where radiation is all around us. It's part of the world we live in. And to say that everything that's radiation is bad is absolutely incorrect. So another thing, if you have a patient who's particularly worried, what I find is when I show them their PET scan, the image that shows them where in their body the medication went, and they can literally see, they can spin it around, they can look, they can say, I can see the dots that are lighting up on the PET scan, and Jeff Johnson, I can show them and say, that's where your cancer is hiding, that's where it's alive, and that's where the medication went. And when we give you the therapeutic version, that's where it's going to deliver its radiation. And that's a very calming thing because it's very visual. It's hard to ignore, and it's actually true.
As I'm listening to you both talk, are you finding this therapy to be something of value to those who may have run out of options?
Well, that's exactly the category of patients that we have to enroll in the clinical trials. Because of the way clinical trials are designed, you have to wait for a patient to go through all the other stuff that Dr. Johnson mentioned, hormonal ablation therapy, where basically they're chemically castrated, and yes, it's their last hope.
I wonder how long it might take, Dr. Sgouros, to get radiopharmaceuticals to become first line treatments.
That's a great question. So there are, and I like your term, first line is exactly the right phrase. There is a clinical trial going on right now where the agent that treats prostate cancer, the lutetium labeled agent, is being examined as a first line treatment. All of these things really have to go through a rigorous evaluation, and we're always up against other treatment modalities, as we should be. We have to prove that these things are better than what else is available.
Say, Dr. Johnson,
Yep.
where do you think this field might be going? This is Tomorrow's Cure podcast, so we're focusing on the future here. What things might be down the pike when it comes to this therapy?
We're looking to say, well, right at the very beginning, can we use these radiopharmaceutical therapies to stop the cancer before it spreads too far? And part of that is because these drugs have low toxicity, meaning so they don't cause much harm, which allows us to move them into healthier and healthier patients who have longer and longer life, because the toxic effects we're hoping will continue to be minimal. There's a study where they looked at giving these therapies prior to surgery to say, why don't we give a radiopharmaceutical therapy to kill cells that are around the cancer that the surgeon might leave behind? So it's called neoadjuvant, or before surgery, and see whether we reduce the chances of the cancer coming back. So we're absolutely using them in literally every phase of cancer care in clinical trials. And I see that coming. I see combinations with other therapies. I see people combining different versions of radiopharmaceutical therapies because there are advantages and disadvantages to alphas and betas. And like I said before, together with immunotherapy, chemotherapy, external radiation, they're complementary. So those give us the hope that this whole new class will enhance the function of the other therapies we already have.
Dr. Sgouros, you've spent 40 plus years working on this, doctor, and I mentioned you're a pioneer in the field. Why were you always convinced that this was going to work? It seems like you were very much right in your assessment of the technology, but I'm just curious as to why you were always a believer in this therapy.
Right. It's so, I guess it's having a physics background and understanding exactly how the modality works. I guess I'm stubborn, and finally, I feel that the field finally caught up to what I was saying. I remember a time when I talk about alpha emitters, and people would say, "Okay, show us the proof that they're actually going to do something." Finally, I think I'm well known in the field because I've been in it for so long. I think that's the root of it. I just was stubborn. I didn't want to give this up and move on to something else.
I wonder, as you look into the future here, where do you think ultimately this may end up in, say, 10, 20 years?
I certainly do think, for the same reasons, I think that alpha emitters are going to make a huge difference. Um, I think the imaging, the technology is going to also profoundly impact how these agents are used. And I want to make sure that the clear message is that these are fundamentally different. They work by a very different mode of action in terms of how they kill cells. They're not agents that are looking to interrupt a cancer pathway. They are agents that kill cells, and unlike chemotherapy, they kill cells specifically in a targeted, sort of precise manner.
It almost sounds like there's a bit of an art to this.
Oh, there definitely is, Kathy. So when let's say you're in the lab, and I've got a background in chemical engineering, so I speak enough of the language that I get to work with the chemists, and I give them my ideas from the patient experience that I want and the imaging and things, and they work on the molecules, and we come up with these things. And with a radiopharmaceutical, like George said, we don't have to worry about that. We just have to get the medication to stick to the cancer cell, right? And so, but the negative side of it is we can't let it go anywhere else. So chemotherapeutic is floating in the blood, isn't doing anything, isn't hurting anything, but a radiopharmaceutical potentially is. So we want it to get to the cancer and only go to the cancer. So the art comes in where you're like, oh, I'm gonna modify the molecule this way. I'm gonna change the chemical charge. I'm gonna change this structure. With each of those tweaks, it is art, because when you put the molecule into a patient, there are so many factors going on. It's so complex. There's no way to know in advance with precision where the molecule is going to go. And so often you have to make different versions of it, and you have to do some trial and error. And the art comes in on the design side of the therapies in that way, absolutely.
You know what I love as I'm watching you and listening to both of you talk, you clearly both are very excited about this. I love your energy and your passion. It comes right through. And how excited are you by all of this? Obviously, Dr. Dr. Sgouros, you've been working on this for, as I say, for 40 plus years, but you seem you're just as excited now as you were before.
I mean, as I said, I believed in this, and I've stuck with it for 40 some years. And finally, it's coming around. People have caught up. And what's interesting, a lot of people have said that to me about having stuck with it. So yes, I am very enthusiastic, and the tone of my voice changes, and I suddenly start waving my hands. And it's very rewarding.
You know what? This conversation has been absolutely fascinating. Dr. Sgouros and Dr. Johnson, thank you for your time and for your good work.
Thank you, Kathy.
Thank you. Thank you, Kathy. Yeah.
Go to tomorrowscure.com for more episodes and information, and subscribe wherever you get your podcasts. Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our senior producer is Nancy Rosenbaum. Our theme was composed and produced by Terrence Bernardo, and the show is mixed by Tommy Bazarian. We had research and production support from David Newtown, Deborah Balthazar, and Genevieve Sponsler. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. The Mayo Clinic production team includes Alex White, Pui Hong Ang, Margaret Shepard, Samantha Clarkson, Kara Mangold, Felipe Sosa, Kim Ona, and Bryn Sankey. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure on iHeart, Spotify, or wherever you get your podcasts. I'm your host, Kathy Wurzer. Thanks for listening.